Thanks for the kind introduction to Amir and Novonady's team to give me opportunity as a speaker of this evening. So today I am going to discuss the insulins achieving total control with insulin co-formulation, a patient-centric approach. This is my financial disclosure, and today's agenda is divided into three parts. The part 1 is the conundrum of the diabetes management, and the part 2 is 2-in-1 co-formulation for total control, and part 3 is practical dosing recommendations. And coming to the part 1, this is a case presentation. The patient's name is Mrs. Shubha, age 58 years old, having diabetes. She is accountant by profession. She had diabetes, type 2 diabetes since 10 years. She had systemic hypertension since 3 years, dyslipidemia since 3 years. And she is on current medications, tablet metformin 1 gram twice a day, and tablet rimipride 1 milligrams twice a day, tablet empagliflozin 25 milligrams once a day, and tablet telmisartan 40 milligrams once a day, and tablet atorvastatin 40 milligrams once a day. And the investigations 1 month ago are: the fasting plasma glucose is 172 milligrams per deciliter, and postprandial glucose is 242 milligrams per deciliter, and her HbA1c is 9.1%. With this data, we coming to a conclusion: she has uncontrolled type 2 diabetes, and she has with comorbidities hypertension and dyslipidemia. Even on subsequent follow-up, the postprandial glucose show a rising trend. How do we manage such a case? So the key challenges for diabetes management in India. One is poor glycemic control. Only less than 30% of the adults with type 2 diabetes in India are up to the mark, that is HbA1c is less than 7%. That is more than 76.6% of adults with type 2 DM in India fail to achieve glycosylated hemoglobin of less than 7%. And second one is poor postprandial glucose control. Less than 83% of the adults with type 2 diabetes mellitus in India have suboptimal postprandial glucose control. And coming to the third one, therapeutic inertia. 10% of the adults with type 2 diabetes mellitus in India received an injectable treatment after 10 years, maybe because of patient's inertia or clinical inertia or the clinician inertia. The patients are afraid of taking insulins for control of the type 2 diabetes mellitus for achieving glycemic control. And adherence to diet. Only 38% of the total type 2 diabetes mellitus participants adhere to a diet, but rest of the people are taking imprudent diet. And last one is the hypoglycemia. People with type 2 diabetes mellitus in Southeast Asia have an estimated 3.4 severe and 14.6 non-severe hypoglycemic events per year. So many factors play a role in the management of diabetes in India, particularly in type 2 diabetes mellitus, because the Asian Indian phenotype is the first one, and the family history is the second one, and the poor diet, that is high carbohydrate diet, and lack of exercise, sedentary lifestyle, all these factors predispose to the type 2 diabetes mellitus. And second one is a delayed diagnosis of type 2 diabetes mellitus, and the third one is a low disease awareness among the public. They take the diabetes as so light, so they neglect the diabetes and didn't follow the doctor's instructions to maintain the glycemic control. And genetic and environmental factors also play a role in the management of diabetes. And when the limited health facilities in India also play a role in the diabetes management, and the high cost of disease treatment. Nowadays, medicines prices are going like anything, so cost of the treatment becoming burden to the management of diabetes, and rising rate of diabetes, and rising prevalence of diabetes in young adults, and rising prevalence in not only in rural urban areas also play a role in management of diabetes. Coming to the postprandial glucose excursions may be an unmet need of the management in Asian population. So this slide shows insulin naive patients and insulin experienced patients. The blue color represents the Asian population, and the green color represents the non-Asian population. This graph shows the an x-axis breakfast, lunch and evening meal, and the y-axis shows the postprandial increments SMBG milligrams per deciliter. So in all the slides, the Asian population, the glucose postprandial increments are high when compared with the non-Asian population. When coming to the breakfast, there is a hike of 28.6 mg milligrams per deciliter hike of postprandial glucose when compared with non-Asians. When coming to the lunch, 17.34 milligrams per deciliters increment of postprandial glucose is seen in Asians. And coming to the evening meal, 16.19 milligrams per deciliter in insulin naive patients. Coming to the insulin experienced patients also, there is a rise in the postprandial glucose increments when compared with the non-Asian population, maybe because of the high insulin resistance in Asians. So evidence from the Indian studies: high postprandial glucose and high HbA1c. This slide shows the various studies: the Indian Diabetes Care Index study and DiabCare study, A1 Achieve study, Present study and Improve study. And this study compares the postprandial glucose and high HbA1c. This in Indian Diabetes Care Index study, the HbA1c is 8.59 and the fasting plasma glucose is 176 milligrams per deciliter and postprandial glucose is 256 milligrams per deciliter. And coming to the DiabCare study, the HbA1c is 8.9% and the fasting plasma glucose is 148 milligrams per deciliter and postprandial glucose is 205 milligrams per deciliter. Coming to the A1 Achieve study, the fasting plasma glucose is 194 milligrams per deciliter and postprandial glucose is 289 milligrams per deciliter and the A1c is 9.2 higher side. And the present study, the HbA1c is 9.2 and fasting plasma glucose is 194 milligrams per deciliter and postprandial glucose is 285 milligrams per deciliter. Coming to the Improve study, HbA1c is 9.3% and fasting plasma glucose is 192 milligrams per deciliter and postprandial glucose is 279 milligrams per deciliter. All these studies shows higher HbA1c and higher fasting and postprandial glucose, which leads to the comorbidities like macrovascular complications and macrovascular complications of diabetes. The uncontrolled glycemia in India demands timely treatment, optimization and insulin therapy. So what are the factors? High carbohydrate diet is the common Indian reality. So according to the STARCH study, dietary survey in Indian type 2 diabetes population, 61 to 70% energy intake in Indians is through carbohydrates present in the diet. High carbohydrate diet leads to raised postprandial glucose levels. So the Indian Diabetes Care Index study shows the number of participants are 3,50,000 and mean age is 55.2 plus or minus 11.9 years, and glycosylated hemoglobin is 8.56 plus or minus 1.8. Fasting plasma glucose is 172 milligrams per deciliter and postprandial glucose is 253 milligrams per deciliter. So all these, in this Indian study, the high intake of carbohydrate leads to high blood glucose levels either fasting or postprandial, and leads to a high HbA1c, so leads to complications. So more than 83% of patients had postprandial glucose more than 160 milligrams per deciliter. Coming to the oral anti-diabetic drugs inadequacy, the lessening effect. This slide shows with two oral anti-diabetic drugs in type 2 diabetes patients, the mean reduction of HbA1c is 1%. With three oral anti-diabetic drugs, the reduction of HbA1c is 0.5%. Adding on fourth drug with four oral anti-diabetic drugs, after treatment there is increase of glycosylated hemoglobin instead of decreasing 0.2% increase in the HbA1c. So at this stage, with more than three oral antibiotic drugs, there is a high time to introduce insulin or initiate insulin to achieve the good glycemic control. So at this stage, we should initiate insulin. So with the insulin, the HbA1c, the glycosylated hemoglobin, has come down by 1.3%. A clinical situation where glycosylated hemoglobin remains above goal despite concurrent use of optimum dose of three oral glucose lowering agents of different classes, one of which should be metformin, insulin sensitizer, and the second preferably sulfonylurea, insulin secretagogue, provided adequate diet and exercise have been followed and comorbid conditions causing hyperglycemia must be ruled out.